With me are Dr. Rajasekhar, a senior consultant cardiologist, and Dr. Aditya, again a senior consultant cardiologist, myself, Dr. Sashikanth, and yeah.
Ajay is here, Ajay Kirtane is here, and then Frank is here,
Thank you.
moderating this side.
Good evening,
Okay.
Dr. Ajay. Good evening, Dr. Frank. Nice to be with you.
How are you?
Thank you. My team, Devi's sister here, Kishore, Naveen, and Chiranjeevi are here to help us with the IVUS imaging. Today we have a case which have been given to us is that we are going to present. Can we have the first slide, please? Yeah. So should we go to the next slide? So we have a 56-year-old male who presented with recent CVA with right hemiparesis with ECG changes and a significant regional wall motion abnormalities, and his tropi was positive. His comorbid features were diabetes mellitus, he was a smoker, hypertensive, and his EGFR was 45 with a serum creatinine of 1.6 with a hemoglobin of 16.5 and an RBS of 215 at the time of admission. He recovered from his CVA about 6 weeks ago with the partial deficit still remaining. His speech and his movement in the lower limb has significantly improved. On doing an echocardiogram, he had a significant regional wall motion abnormalities in the lateral wall, inferior wall, and mild LV systolic dysfunction. ECG showed significant changes. Can we go to the next slide? Yeah, ECG showed significant changes at the time of admission with T-wave inversion in L1 AVL, ST depressions V2 to V5, and his ECG subsequently, just yesterday probably showed a significant improvement in the ECG changes with the treatment what he had received, SIN+. Can you go to the next slide? So that's the video playing there. Video is not playing. So he had a significant wall motion abnormalities in the inferior wall, posterior wall, and lateral wall. And can we go to the next slide? Mild TR, mild mitral regurgitation, RV systolic pressure of 48. This is the angiogram, what is there. Can you play the angiogram? Shashi? Can you play the angiogram?
You can show today's pictures otherwise.
No, today's the concept today is zero contrast PCI.
Okay.
So we are showing you the recorded PCI there. Can you see the images now?
Yes.
Okay, previous scene. Previous one. Yeah, previous one. Yeah, that's the right coronary artery with the CTO there. RC has got a significant collaterals from the left system. Next slide. And that's the large short left main with a significant discrete lesion in the circumflex, mid-circumflex, bifurcation lesion with 2 AMs, the next one. And that's the LAD showing a scene. Go to the next scene. That's the LAD for you. A tight lesion in the mid-LAD with some amount of calcification. This is the RAO cranial view scene. Go to the next one. So RAO cranial view showing a long segment LAD lesion, and that's the collaterals to the right coronary artery. Can you go to the next slide? And that's the LAO caudal view showing again a significant lesion in the circumflex and the mid-LAD. So this was a gentleman who was 56 years old, long-standing diabetes, smoker, hypertensive. Post-angiogram, his creatinine jumped up from 1.6 to 3.4. His EGFR came down from 45 to 18. And we had a situation wherein he was tropi positive and we had to do something, though he was not having a significant angina, but we thought we should do something here. And we had the right time session for doing this case live. So we plan to do a zero contrast PCI, and that was the strategy. I think Dr. Rajasekhar would like to make a comment on how you plan to do this case.
Maybe just one question to you. This is a young gentleman with really severe cerebral disease, definitely. And did you discuss the option to send them for CABG?
Yes. So we did discuss the option with the family of going for a CABG, triple vessel disease, diabetes mellitus with mild LV systolic dysfunction. The family was not willing for a renal replacement therapy. The family was not willing for a bypass surgery. So we had the option of doing an image-guided PCI with an ultra-low volume contrast. Can you see the slide on the screen there?
Yes.
Yeah. So his creatinine significantly jumped, and this is just immediately post-angiogram. So we waited almost 4 weeks now for his creatinine to settle down. It's remained almost 3.4. So we started yesterday with him hydration, N-acetylcysteine, and the routine renal protection measures. and we thought we'll post him for a PCI today, image-guided PCI with an ultra-low volume contrast. We have done previous cases with ultra-low volume contrast and had a good success with no rise in creatinine. In fact, the creatinine decreased with the hydration therapy what we had given. So we did discuss with the family, and we thought this is a better option for him now, because RCA is non-viable. It boils down to a two-vessel territory, circumflex and LAD. LAD is a straightforward lesion, mild calcification, and the circumflex again, mid-circumflex discrete lesion, not very long, not very difficult anatomy. So we thought we should be able to do a PCI for him, especially with his hemiplegia, hemiparesis what he has. He has some mild deficit still remaining in the right upper limb.
So you focus your attention to mid part of the LAD and the mid part of the circ.
Yes.
And that's it. I think this is a suitable options if patients refuse to go for cabbage.
True.
And what I have done in my practice, so we sometimes go with similar approach, and we use gadolinium for final shot. This is also working procedure.
So we have a lot of advanced coronary artery disease patients coming in with a high incidence of comorbidities, especially with CKD, and this patient had an acute kidney injury post-contrast. The cardiovascular management is becoming quite challenging for this group of patients, and we have a significant innovation in technology which has changed the way we plan, changed the way we perform the PCI. Then we know that there's a strong correlation between the contrast volume and the role and the risk for acute kidney injury. So every increment of about 75 ml of contrast use increases the risk of acute kidney injury by about 42% as by the NCDR cath PCI registry. So here we have a patient who had an acute kidney injury, and the creatinine is not settling down in spite of 1 month of waiting. So we thought we should be doing a low volume contrast PCI, especially when the patient had a CVA recently and he's a high risk individual, and the family is not accepting a surgery and also not accepting for a renal replacement therapy if in case needed post bypass surgery. Those are the strong indications we had to think about this. Any suggestion from Dr. Ajay? Do you have any other strategy, or would you still insist that this patient should go for a bypass surgery? Dr. Ajay?
You know, it's a very difficult situation to make as, not seeing the patient and being there and that sort of thing. But there are cases where it's a clear surgery is the best answer. And in those cases, I do refuse to do PCI, but this does not sound like one of those cases at all. And I think you have to try to put yourself in the patient and the family's shoes and understand what's best for them. And if the comorbidities are such that it precludes surgery, then I think PCI is a reasonable option.
Right. So what we have done so far, we've recorded a few images so far. Can we go to the first slide?
Go to the first scene.
So we had the previous angiogram playing on the screen. So we decided to go with the femoral route. And Dr. Rajasekhar, please go ahead.
So we have done a few steps already for saving time for this workshop. And we have put in an 8 French sheath and we use an 8 French guiding catheter. I will come to the reason why we opted for an 8 French. We engaged the guiding, and based on the fluoroscopic picture and the movement of the catheter, we realized that we have engaged. And so far we haven't used a single ml of contrast. So we have parked 2 wires in the distal LAD, and over 1 wire we have introduced the IVUS catheter. We use the Boston Scientific HD IVUS. We put in the IVUS catheter, and I can show you the first IVUS run.
The IVUS run, the first IVUS run. Aditya, Dr. Aditya?
Yeah, so we have the catheter parked in beyond the lesion.
Can you be a little louder?
Can you be a little louder?
Yeah, we can see there's a fairly healthy vessel beyond the lesion, and there's a HD IVUS catheter. We get beautiful images. So the distal vessel size is approximating around 3 millimeters, and as we do the pullback, now we can see that the plaque is mixed fibrofatty plaque with a fair bit of calcium. And now this is the most severely stenosed part, and we have an extensive calcified ring around an arc of around 270 to 360 degrees. And at this point we see there's a lot of positive remodeling. The vessel has grown up in size, and it's almost 4 millimeters. As we reach the more proximal LAD, we can see again mixed fibrofatty plaque with calcium. So we are probably reaching the proximal landing zone with a tiny bit of calcium, and we feel the vessel has grown up to nearly 4.5 millimeters with a lot of positive remodeling. No evidence of any flap, thrombus.
So the strategy at this point was to pass the IVUS catheter and define the anatomy as we had seen in the angiogram, see the location of the lesion, the severity of the lesion. We already have the information, but the IVUS did help us in making this decision. Diffuse disease from the proximal LAD, we had a significant, this is the point where the proximal LAD, we have a good landing zone before the circumflex, and so we did measure the severity of the stenosis there. We looked at the calcium, we looked at the plaque morphology, we looked at the distal landing site, the diameter of the vessel distally, the landing zone proximally, and we took a measurement by the IVUS. We also did a angiogram and an IVUS catheter co-registration. Actually, we don't have a co-registration in our lab, and so we did a angio and IVUS catheter correlation co-registration, and we can you go to the next one?
Next scene.
And so we decided to we put the IVUS catheter distally in the normal healthy landing zone. Can you go to the next angiofilm, please? Next one, next one, next one. And that's the point on the angiogram where the proximal LAD has a normal healthy segment or the plaque burden of less than 20% or so. So that's the point where we wanted to end the stent proximally. And distal landing zone was also marked. There's a small bit of calcium in the mid LAD, which beyond that, about 12 millimeters beyond that is the healthy landing zone in the mid LAD. So that's how we strategize. Go to the next one, next cine run. Next cine run. And on the second wire, we took a 3 into 12 millimeter balloon parallel to the IVUS catheter to see the distal pre-dilatation of the vessel. The distal pre-dilatation of the vessel, we did a IVUS assessment where the balloon inflation should start. So that is the safe landing zone. And can you go to the next one?
Next scene.
Now that's the safe landing zone. We pulled the IVUS catheter back, marked the position of the balloon, gave an inflation there. Next one. Next one. So the entire length of the LAD, we did a pre-dilatation with a 3 into 12 millimeter balloon at graded inflations. The next one. No. Can you go to this next one? Next one. Forward. Go back. 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 No, with the balloon. Yeah. So this is the point. We put the proximal marker of the IVUS catheter in the left main, just at the ostium of the LAD, and that's where we gave the last inflation in the LAD. So here we have marked the proximal landing zone, the distal landing zone, and like Dr. Aditya said, the distal landing zone, the vessel size is about 3 millimeters. Proximally, the vessel is about 4.2 millimeters. So there's a graded size of the vessel there. So we thought we will take a stent, and can we have the stent? So we did a pre-dilatation with a 3 into 12 balloon. We're going to position the IVUS catheter distally at the distal landing zone. Can you see the images? Any suggestions from Dr. Frank, Dr. Ajay Kirtane?
So from my point,
No, I think yeah, go ahead.
Yeah, from my point of view, a very safe approach. But you need femoral access. You need really 8 French guiding to have the option to
Yes. We are using an 8 French guiding catheter.
And to put stent. So definitely you need 8 French.
Yes.
From my point of experience, I think to make an IVUS, as you suggested, to see how long is the lesion and to mark this lesion with, from my point of view, it will be enough to mark this lesion with.
So can we have the live IVUS now?
Radio-epac part of floppy wire. This will be, from my perspective, also enough. And to see how is distal diameter, not to overstretch the vessel, not to risk distal dissection, H dissection.
Yeah. So the IVUS catheter is now distal to the stent, distal marker of the stent, and here you see the healthy vessel there.
Mm-hmm.
Now we know they were landing the stent in the healthy segment there. It's almost a 3 millimeter vessel there. So we fix the position of the stent, pull the IVUS catheter back up to the ostium of the LAD. Visualize the ostium of the LAD and the circumflex where we have a healthy zone landing. Negative pressure, neutral pressure. So we took a 3 into 48 millimeter stent. The lesion measured 46 millimeters to be exact. And can you?
So you have 8 French guiding catheter.
Yes,
in
we
the
have
left.
8 French guiding catheter. We are not worried about the catheter with the contrast usage because we're not using contrast there. So it's just an 8 French guiding catheter. The left main is quite roomy, quite a big left main. Can you go a little 1 millimeter in? Can you go 1 millimeter in with the IVUS catheter, please? Yeah. Can 1 more millimeter? I want to see the ostium of the circumflex. Back.
So, you know, it's interesting. Another way to do this without doing it 8 French and having things be done simultaneously is to mark the branches with wires.
Yes.
And you know, this has been described when Ziad was at Columbia, you know, as sort of a silhouette, the metal silhouette, and with marking with wires, and then going in with the IVUS, doing cines when you see where the IVUS is, you can then co-register it that way. And we've actually had pretty good results doing it that way as well. But it's very interesting to see this approach.
Yeah. So now we have marked the distal landing. We are marking the proximal part of the LAD, and that's the IVUS image showing you there, a mild plaque. Can we have a small pullback of the IVUS catheter? A little small pullback of the IVUS catheter. I'm pulling it back. Yeah. Okay.
Do you plan to remove the second wire because one?
Yes. Once we position the stent, we're going to remove the IVUS catheter. Yeah, this is the landing zone. This is good. This is good. So the stent can come back by 2 millimeters.
Remove the wire, and so there's still some option to miss the perfect position. You should know this.
We can jail the IVUS catheter. The camera, the most part of the IVUS catheter is out actually. Here, let's have. Can we push the IVUS catheter a little more in? Yes. Stop there. Live image, please, of the IVUS. Okay, that's good position. We have a mild plaque in the proximal LAD. Pull back a little bit with the IVUS catheter. See the ostium of the circumflex. Okay, I think that's a good position there. What we have, we'll go ahead and deploy Dr. Rajasekhar.
Yeah, we'll deploy.
Ajay, what other Ajay suggested option, at least for LCX being the major vessel you're trying to avoid closing to ostium, we could also position a wire in LCX.
Exactly.
Yes, we thought about it. We thought about it, putting a wire in the circumflex. But we have a good IVUS image there telling us the ostium of the circumflex, showing us the ostium of the circumflex and the LAD. Can you go a little more in? Raj, can you go a little more in?
The wire in the LCX will be really very useful.
I know. It's like the IVUS catheter here, it's also subject to movement. Like when we are pulling back the IVUS catheter, it could move. So we thought this is the better way of positioning the proximal part of the stent. Now the marker of the IVUS catheter, the eye of the IVUS catheter and the proximal marker of the stent are aligned, and you know that we are in a good healthy landing zone of the LAD. The proximal landing zone is quite good, so I would like to inflate the stent here.
IVUS catheter.
It's okay. It's
IVUS and wire should be taken out.
No, it's okay. Go ahead.
Go ahead.
2, 4, 6, 8. What's nominal pressure? 11. Go to 11. Okay. Deflate. So we have deployed the stent. Hemodynamically stable. There is a little bit of ST depression seen. His heart rate is about 120 now. Pressures are quite good, 160, 110. And we have deployed the stent.
I will come out with the IVUS catheter.
So now we're coming out with the IVUS catheter.
Yeah, it's jailed.
Yeah, it's okay. We pulled it out. We do jail balloons when we're doing the side branch inflation sometimes, when we have a very large vessel which may be compromised during PCI. So now the IVUS catheter has been removed. Now we're going to remove the balloon. We're going to give one more inflation with the balloon before we take it out. One more inflation with the balloon. And that's we have the stent boost telling us the stent is reasonably expanded there. 11.
12.
Just remember, though, if you're gonna, I would say jailing a balloon is a very different thing than jailing an IVUS catheter because of the very short monorail.
I know.
So I would do everything you can not to jail the tip of the IVUS catheter.
I will take your suggestion, sir. It's true. It's.
Please don't do this. Will be really very
Oh,
difficult.
one more thing is, what was the advantage of keeping it there anyway? Once you have positioned the stent, you could have taken it and inflated or no?
The stent moves sometimes when you're push-pull technique. The stent moves sometimes and misses the ostium.
Well, this is the reason why we retain the IVUS. Albeit, I think the point is very well taken because of the difficulty of leaving an IVUS catheter jailed, is that because we are very close to the ostium and we have a circumflex lesion that needs to be fixed. So we needed to be extremely precise. The margin for error was minimal, and that's why I thought we had the absolute confidence that we are a little off the ostium by the position of the eye of the IVUS catheter.
Yeah, but if you go with the wired circ, you have wonderful option to see where to stop with the stent in LAD.
Yeah.
Yeah, I mean, especially because you have an 8 French guide.
Yeah.
I would say, and again, because this is a teaching course, I would say the safer way to do this is you put a wire in the circumflex, you put the IVUS catheter in the circumflex, and then you'll be able to get a view of the ostium of the LAD via the circumflex, and you would know exactly where you were, and you would not have to jail the IVUS catheter.
Yes, we did.
We did discuss this
We
option
discussed
too.
this option too.
We did discuss this option too. We did it sometimes with the IVUS catheter in the circumflex and stent the ostial LAD, but this we felt was probably getting it more accurate, seeing it from the same vessel rather than from the side branch, because NC balloon 312.
I agree with accuracy, but when you're sacrificing safety at the expense of accuracy, then you perhaps take. And I actually think if you're looking from the circ, there's no way you're going to hang back into the left main because you know exactly where you are, and it's more safe. I don't think, frankly, without a large series of patients, without a large series of patients, I don't see how you can. At this point, I don't think we as a group should recommend routinely jailing IVUS catheters behind stents.
I think point is well taken. Yes.
This is a 3x12 balloon. We are doing a post dilatation. Get the IVUS catheter ready. We'll do a quick. Give me this. I'll do this.
If I see correct, you have still jailed wire now in position, right? Or
we have removed the wire.
The wire is removed. The second wire is removed.
Not perfect.
The 14.
The wire as well as the IVUS.
The wire and the IVUS catheter have been removed easily. In fact, it just came out very easily without any resistance, significant resistance. I would not say this would be the same when the vessel is heavily calcified. 16.
Yeah, don't forget to. I would like to mention that this point. If you have troubles with to remove wires, and if your 8 French guiding catheter is pushing forward, so you can make really huge dissection and even risk the flow in the.
Agreed, sir. Here we had a
agreed.
situation wherein the left main was almost like 7 millimeters, 16, 4 millimeter balloon NC. So get the IVUS catheter ready. We are going to go ahead with the proximal inflations with the 4 millimeter balloon and giving you a IVUS run. 18. So the stent boost is another way you can study these pictures. The only thing at this time when we would like to inject contrast is when the patient is becoming hemodynamically unstable, going up. Hemodynamically unstable, there are ECG changes, patient is having a pain. In that situation, my zero contrast PCI would not be the priority. Safety would be the priority. In that situation, I would inject and see what is happening. Is it a proximal dissection?
Heart rate periginda.
Yeah.
Talk to the patient.
Talk to the patient.
So
how is he? Yes, sir.
So your next step will be now to go with IVUS to check now.
We will do
the patient is good. He has no symptoms.
We will do a 4 millimeter dilatation.
We take a 4 millimeter dilatation. We have marked on the angiogram. We took a cine shot at what point in the IVUS run the vessel has changed from a 3 millimeter vessel to a 4 millimeter vessel. We have did a angio co-registration with the IVUS catheter tip, and we know at what point we have to go with a 4 millimeter dilatation. Just proximal to that calcium there, we are doing a 4 millimeter. Yeah, that's the point. A little bit distally.
So what we see now, there's a really high pressure in this patient. So
yes,
nearly
180, 180. Does he have an angina? Does he have an angina? Can somebody see? 14 millimeters.
So it's practically a kind of
no angina. He has no angina as of now. Yes, his pressures are going up, going with inflation.
He's a little anxious, I think.
Going up at 14 atmospheres.
Did you make some kind of
some NTG, please?
Sedation in such situation?
Yes, the anesthetist is here. She's taking care of him. 18 atmospheres.
We can't see really in detail the picture, but it 18. Looks nicely. I think the proximal part
NTG,
still
please. What's the guiding lights? What's the
guiding really lights? Perfect open.
What's the guiding lights? Okay.
Now you have probably to 10. Give much more.
10, 12?
Yep.
Okay.
It's probably not enough. You have to go with a higher pressure.
Yeah. We'll just do an IVUS run. We'll just do an IVUS run.
Degree
Going one more inflation. Okay, I'm going to 12 atmospheres.
Do you have echo machine in
yes, it is ready. It is ready. In the cath lab, it is ready. Can we do an echo?
Fusion in the patients will have some chest pain, so you immediately.
There are some ECG changes. Yes, it's one possibility. Can we have the echo? Yes, we'll have it for in a few seconds. We'll have the patient is IVUS run. అమర్నాథ్ గారు ఎట్లున్నారు బాగున్నారా gave a little of nitroglycerine and we'll take an IVUS run.
Yeah, that's very good because pressure is increasing now over 200.
No, that's the lower limb pressure. That's the NIV. That's the
it's 140,
pressure in the lower limb.
140 by 100.
140 by 108. Flash mark. Go. Keep flashing.
He is a renal failure patient, but otherwise when the patient's bladder gets full also pressure keeps going up.
Yeah, agreed. Very common reason. Nice way of troubleshooting, Dr. Srinivas. Thank you. So we did some zero contrast PCI in a very complex PCI patients with rotablation. With the 2 or 3 stents in LAD, but using the calcium as one of the markers for the location of the distal stent, the proximal stent, the landing zones, and truly a zero contrast PCI can be done today. It's basically the mindset that has to change. So, did you start the run? The IVUS run has been initiated now, and the catheter gone quite distally. Why is his heart rate going up?
Can you show the IVUS live?
Yes, we are showing the IVUS live. So here is the stent.
Check remove the slides. Yeah.
So the distal stent is well expanded, well opposed. At whatever point we think we have a underdilatation of the stent, we will do a cine, mark that area. Okay, that's the point where we would like to go in. Cine, yeah, that's the point we would like to do again a post dilatation there. The stent is not fully expanded there. And again here, cine, the short run here, the stent is not fully expanded there. A significant calcium there. We did prepare the vessel with a good amount of vessel bed preparation there, and that's the 4 mm segment of the vessel there. Again, a little bit of post dilatation is needed there.
I think you have done demonstration well, and again post dilatation with the bigger balloon, high pressure, you would optimize the stent result. We understand that, and we are running short of time. If you permit, we'll go to Care Hospital back, and we need 1 minute, and then we'll end the session.
Okay.
Thank you, Sashikanth and Rajasekhar, for excellent demonstration.
Thank you so
Any
much.
final comments, Ajay or Farang sir, on this? We'll go to Care Hospital.
Well, the only final comment I would make is that there's a lot of notoriety around zero contrast PCI, and the idea is not to be zero.
No,
the idea is to be low.
Absolutely.
And I think as you mentioned, the specific criteria when you would potentially have to use it.
Yes.
But you're able to do this now with the use of imaging, specifically IVUS, during these cases. So it's a great demonstration of that. So thank you so much.
Yeah.
Thank you.
Also from my point of view, congratulations to this demonstration, I think it was in this case really zero contrast dose. But as AJ mentioned, safety first, and if you're in doubt, please you can even
We're off live.
amount.
No, Rajasekhar.
Yes.
Thank you very much, Dr. Srinivas, Dr. Farang, Dr. Ajay.
Thank you so much.
It's been a pleasure
Fantastic.
interacting with you.
Thank you, Dr. Srinivas. Thank you, Dr. Ajay. Thank you, Dr. Frank.
And just
Yeah.
Right,
And
Namaste. I am Dr. A. Srinivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings best wishes from FACS Foundation and TCT India South Asia 2021. This live case learning video is about an interesting case of zero contrast PCI done by Dr. Sashikanth and Dr. Rajasekhar from Yashoda Hospital, Secunderabad. What we have learned in this interesting case is actually to know what is zero contrast or low contrast PCI. Obviously, as the name signifies, we don't want to use contrast at all if possible, or use very minimal contrast while doing PCI. But at the same time, we should be able to do a good job to the patient and give good outcomes. So if you have to see how to do it, in this case, probably they have used a femoral root, the 8 French sheath and 8 French guide, placing 2 wires, and one wire is being used for IVUS monitoring throughout the procedure, and the other wire is used like a standard PCI 014 wire on which balloons were advanced and then the stents were taken. And after the balloon dilatation is done, again pre and post dilatations, IVUS was checked in to decide which is the normal segment from where to start and where to end. And ideally, if you have facility of angio and IVUS co-registration, you could mark that and do that markings. As it was not available in that lab, what they did is an equivalent to that by marking, taking the angiocene loops at the various points of interest which are identified in the intravascular ultrasound. Obviously, we need to have baseline angiographic pictures probably taken prior to deciding on the zero contrast PCI. Here, this patient, the procedure was done elsewhere. After an inferior wall MI, then inferior RCA territory was scarred, and then LAD had a significant critical stenosis. And this time patient presented with anterior non-Q type of ECG changes with troponin elevation. But after the diagnostic angiogram, patient had a significant rise in creatinine from 1.6 to 3.4, which persisted in spite of waiting for about 4 weeks after the procedure. But in view of his ACS presentation with ECG changes, it was decided to take care of this patient by zero contrast PCI. Coming to other methods of how to perform this zero contrast PCI, what was suggested by Dr. Ajay Kirtane, actually who was also involved in a lot of zero contrast and low contrast PCI studies and publications along with Ziad Ali from Columbia University. What he mentioned is, even if you have to use a 6 French catheter also, you could take the help of wire placements in the various branches and identify from which place to which place you have to position the balloon and stent by taking the branches as a landmark, again using those wires which was placed in those branches. So it is like a metallic contouring of the vessel with the help of 014 wires which are taken. Other very important point which was suggested is also, if we are taking the stent up to the proximal vessels, it is always better, especially in the LED, if you are doing it like a near proximal or ostial stenting, it's always important to keep another wire in LCX so that LCX it should not impinge too much onto the LCX, and it was also checked effectively by intravascular ultrasound. When the operators used to keep the, again, IVUS catheter and jailed it by stent implantation. Dr. Rajasekhar specifically mentioned that it should not be taken as jailing like balloons or wires. Sometimes the IVUS catheters could break. So it is not advisable to jail the IVUS catheter before the final stenting. So in other words, in fact, what he recommended was, if you are very particular about osteal placement, you could actually pass IVUS catheter through the LCX ostium and then probably still do a precise placement of stent in the LAD, which are without impinging onto the L6 ostium or coming into the left main. So this was a very important point which all of us learned in this zero contrast and low contrast PCI. And obviously, once the IVUS catheter is removed after stenting, then again post-dilatations with the bigger size balloons and approximation of the stent well in those areas which are under expanded, and also the probably according to sizing of the vessel, the distal vessel was about 3 and the proximal vessel was about 4.2. So dilatations with high pressure was done in the proximal segment with a bigger sized balloon. In between, the patient had chest pain and slight ECG changes and hemodynamic disturbances with tachycardia and rise in pressure. And then it is ideal actually to control this by giving IV nitroglycerin and also take a view of whether too much of ischemia is produced or whether we have produced any complication. The exceptions in which from which low contrast or zero contrast to PCI, where we would check is whenever you find there is hemodynamic disturbances in the patient, or when the patient's pressure falls, or any other unusual thing happening, then probably you should not stick on to this philosophy of using no contrast at all, but probably you could check with a minimal contrast, with a VisiPac type of contrast being used. And then because keeping the patient's safety is always a priority, then avoiding a little amount of contrast. This point again was very well highlighted. Then if after the usage and after the end result was assessed throughout, then patient had a very good outcome, good result, and that's how the operators were congratulated. And then this concept of zero contrast PCI, low contrast PCI, again is very useful in patients who had a history of rise in creatinine, like how it happened in this patient, or in patients who already have a elevated creatinine or CKD stage 4-5 type of patients, and they won't want to go on to hemodialysis. It's very important, but it may not be very necessary for patients who have CKD who are already on dialysis, but still in such patients also it could be beneficial. Dr. Ferenc also mentioned that the options of CABG should also be discussed with the patient and the family because of critical nature of all the 3 vessel disease in this patient. But as a family didn't want the patient to go on to renal replacement therapy, especially after bypass surgery if required, and that's how the heart team decided for doing a low contrast PCI in this patient, and that's how the heart team approach was also highlighted. And again, all of us will strive to do good things, good results to these patients. With more and more technology coming up and more such comorbid pathology patients are being taken up, and that's how we are able to improve the outcomes of patients. Another important point which was discussed is regarding how to prevent the occurrence of AKI and what is its relation to usage of contrast. And with each 75 ml increased usage of contrast, what it was thought in such patients, there is again 45% chance of patient developing acute kidney injury and contrast-induced nephropathy and increased mortality. That's why it is very important for all of us to limit the amount of contrast. And it was also discussed how to prevent the occurrence, how to pre-treat these patients with proper hydration and using some therapies like N-acetylcysteine and others were discussed. But obviously, when the most important and the best would be avoiding the contrast altogether by this zero contrast PCI. And this would prevent the occurrence of AKI and decrease complication rates in these patients of CKD. Thank you.